Hi, today in Learn Simply Academy Vaginal Surgery Master Series, the topic is difficult case management, large uterus, limited descent, and adhesions. So, what you will learn the techniques for the large non-descended uterus, managing limited uterine descent safely, navigating pelvic adhesions during vaginal surgery, and knowing when to convert and when to persist. So why it is matters, difficult case demand just judgment, not just skill. Uterine size and descents are the top reasons for the vaginal hysterectomy is abundant for laparotomy. Most difficult uteri are still safely approachable vaginally if you know the right technique. Experiences shift the threshold for what counts as difficult. So experience is very, very important for difficult cases is they just demand and not just the skill. So the framework, what is the defining as what is a difficult case? Large uterus, typically about 12 to 14 weeks. Limited descent, a nulliparous or poorly supported uterus. Distorted anatomy, adhesions prior surgery, and endometriosis. Now, what should be the planning pre-op assessment before a difficult case? Imaging to estimate size, mobility, and adnexal status. Assess vaginal access, introitus, what is the arc, what is the depth. Then review the prior history are likely the adhesions. So these assessments are important before doing any difficult case. Now, what should be the planning when patient selection? What is the informed consent? What is informed counseling is very, very important. So first and foremost, discuss the possibility of conversion to laparotomy. Then the second one is set realistic expectation on the operative time and recovery. So you should know how much time you will take during the surgery, how it is difficult, and how the patient will recover after the surgery. Confirmed consent covers all possible surgical routes. Now, what preparation or setup for the vaginal cases? Optimal lithotomy positioning in adequate exposure, extended instrumental set, long clamps, weighted retractors, confirmed laparoscopic and laparotomy backup is available. So in the large uterus, the general strategy for the uterine size reduction is debulk before attempting delivery to the fundus. Work in the safest available tissue plane first. And important is reassess the size and mobility after each bulking step. Bisection technique, midline incision through cervix into the fundus, creates two mobile halves for easier traction and effective for the moderately enlarged and symmetric uterus. So the large uterus, morcellation and coring technique. Coring removes the central cylindrical core and reduces the bulk. Wedge morcellation removes the myometrial segment sequentially and maintain the traction and visualize the uterine vessels throughout. For large uterus, myomectomy during vaginal hysterectomy, enucleate large fibroids before further debulking, reduces the bulk and improves the subsequent XX, and control the bed with a figure of 8 sutures is needed. Otherwise, cauterization is good. Then monitoring the broad ligament fibroids, identify the ureter before dissecting near the broad ligament, enucleate and restore the normal anatomic planes, and proceed cautiously if ureter cannot be clearly identified. Then limited descent. General strategy for the limited descent is confirm uterine mobility before committing the route. Sequential ligament division improves the descent progressively and reassess the descent after each step before proceeding. Then the key techniques for the non-descended uterus is early uterine artery ligation improves the subsequent access, traction and counteraction with valsellum on the cervix, and systemic stepwise ligament division releases the uterus. For the limited descent, managing narrow vaginal access, adequate episiotomy or sometimes perineal relaxing incisions are needed. Then reposition retractors frequently for the visualization. Do not force traction against a narrow, unyielding introitus. And for the adhesions, recognizing the pelvic adhesions early, history of prior pelvic surgery, infection, or endometriosis. Restricted uterine motility on examination is a biggest red flag that we should know there are adhesions, and unexpected resistance during dissection signals adhesions. Adhesiolysis core principle: sharp dissection close to uterus is safer than the blunt traction. Identify bowel and bladder before dividing in dense adhesions, and proceed incrementally. Reassess the anatomy at every step. So the adhesions: managing dense vesico-uterine adhesions, common after prior cesarean section. Fill the bladder to help to define the margins. If uncertain, sharp dissection in correct plane minimizes bladder injury. Then posterior adhesions, bowel and cul-de-sac, obliterated cul-de-sac, often seen with endometriosis. Identify the rectum clearly before posterior dissection. Consider a rectal probe if plane is unclear. Then additional consideration in very difficult cases like adherent ovaries, tubes need to be careful, gentle mobilization. Plan for possible 𝗥𝐴𝐺𝐸𝗂𝐴 in advance and assess whether adnexa are safely reachable vaginally. Now, what safety we should have while recognizing the injury early? Unexpected fluid, bleeding pattern, or tissue should be a prompt cause. Have a low threshold to inspect bladder and bowel integrity. Early recognition converts a crisis into manageable repair. So decision making: when to convert laparoscopy or laparotomy. Anatomy remains unclear despite careful dissection. Uncontrolled bleeding or suspected visceral injury. Conversion is a sign of good judgment, it's not a failure. Now we need a teamwork. So communication in a difficult cases is verbalize finding, plan changes to the whole team. Call for senior or assistants for help early, not is the last resort. Document decision points clearly in the operative notes. So clinical judgments: these are the pearls and these are the pitfalls. The pearls are: debulk before you deliver, never force traction. Reassess anatomy at every single step. Convert early rather than push through uncertainty. Pitfall: forcing descent against the unclear anatomy, ignoring early signs of visceral injury, and delaying senior help until the case is critical. So the takeaway of this difficult situation, summary and closing: difficult cases are managed with judgment, not with the force. Debulk large uteri systematically before delivery. Sequential ligament division safely resolves limited descent. Dissect adhesions sharply with bladder and bowel identified. Know your threshold to convert and use it without hesitation. Thank you so much for this discussions.